Well, thank you all for coming out tonight. It's a pleasure to see everybody here. I'm glad you all can make it. You know, I chose the topic of breast cancer genetics, and you know, it's frustrating all the time to pick up a news article and see new information about how our genes can impact disease and not really have a clear understanding of all the new changes that are going on. Genetics is confusing, as a lot of science is. And what I'm hoping to do in my talk is to make it a little bit easier to understand. So allow me, if you will, to take you on a brief journey of a way that I use to kind of understand genetics and their role in cancer a little bit better. So I'm actually going to take a walk over here for this slide because it's a little involved. So here you have a young lady, and you know, she's an attractive young lady. I also tend to think of people sometimes in strange ways, having a background in science as I do. But you have to understand that really we are collections of trillions of cells, 10 to 50 trillions of cells in our body. And although we have cells in all different organs that do many different jobs, they have many different roles, they all share one thing in common, and that in their center, they have a core there that we call the nucleus. And inside that nucleus, every cell has a copy of all of our genetic information. Whether or not we use it, whether or not that cell uses all of those genes or not, it has all the information available to it. And I think of this genetic information as, well, actually, you know, we call this genetic information in total, we call it our genome. And this genome is actually broken down into things that we call genes. These genes, actually, I think of them as books. And I think of this nucleus as a big library that houses all these books. Each gene actually is a blueprint. Each of these blueprints encodes one protein, or sometimes more, but it makes it a little more complex. But I think of it as one gene being a blueprint or a book that tells the cell how to make a protein, a specific protein. Now proteins, I kind of think of them as like constructor sets for kids, being a boy. Being a boy one time, having had one of those myself, you can make all kinds of neat things with them. So proteins can be used to do all kinds of different functions for a cell, including proteins can help cells metabolize food, they can help cells divide, which is very important. And when you think of cancer, what cancers actually do, they divide, they spread. And there are some proteins that act to prevent cells from dividing, which is also very important to prevent unchecked division of cells, and to prevent cancers from developing. So all these genes basically are stored in the nucleus, and how I look at this, you know, when we read books, our books are made out of paper. Now genes, they're made out of DNA, which is this material you see here in a strung out format here. In our English language, we have 26 letters. Genes, our genome basically uses, in DNA we use 4 letters. All animals, plants, every living organism basically has a genetic language comprised of 4 letters. And when arranged appropriately, all these letters spell out words, and these words are arranged in a book or in a gene. And our cells use these genes then to help to tell them how to assemble proteins together. Now this DNA, we have to compact it, because actually if you took one single cell and took the DNA and spread it out end to end, it would actually spread across the full length of a tennis court. So we actually have to compress this DNA up very tightly. And we do that by winding it in a helical fashion and then looping it around like this and putting it onto things that we call chromosomes. Chromosomes I think of as big library shelves. You have a library, now you have shelves that we call chromosomes. So these genes are actually found throughout, whoops, how did I get out here? There we go. So here we have a picture showing a display of all the chromosomes that's present in a female patient. And what you'll notice is that these chromosomes are all different sizes, and they come in pairs. And that's because of every chromosome, we get one copy from our mother and one copy from our father. And we know that this collection of chromosomes came from a woman because we see two X chromosomes. And you notice a Y chromosome is actually much shorter. And women, I guess, look at this and say, well, you know, we have a lot more DNA in our X chromosome. That makes us much more special. We're much better than you guys are. We say, hey, a small amount of DNA, that's all we need. That's enough for us. So like I said, the genes act as, genes basically are blueprints for proteins. And as I mentioned, proteins form many different functions. They can act as building materials for cells. They're involved in metabolism. They are actually used as signaling molecules. They help to control how and when cells divide, which again is important in preventing cancer. And they also, very importantly, I think very germane to my portion of the talk, some of these proteins are involved in maintaining the integrity of DNA, preventing DNA from being mutated, preventing other genes from being mutated. It's very important. And maintaining the structural integrity of the chromosomes, keeping them from falling apart, keeping them from being copied, keeping them from being lost. All these are very important roles for certain proteins in our body, in certain genes. So now, how do we link all this to cancer? Well, cancers happen basically in one major theory is that because we accrue a number of mutations in our cells, a number of mutations of these genes. And gene mutations are basically, they're permanent changes made to the DNA sequence. Mutations can be caused by random chance. Actually, most of the mutations that occur in our lifetime happen due to random chance. And then some things in the environment, like chemicals. We know smoking can cause lung cancer. Well, some of these chemicals actually directly damage DNA and change the code that can cause errors to happen in our DNA. If you mess up the book, you don't get the right product, don't get the right protein, and that can have bad consequences. Not all the time, but sometimes for the cell. Radiation also can cause mutations. So these gene mutations they might result in the change in function or a loss of a protein. They can actually cause loss of entire pieces of a chromosome. So many genes can be lost at once. Now, for cancers to occur, for most cancers, they require multiple mutations and multiple genes to happen. It's not like breast cancer happens just because one gene undergoes a change. There are some cancers that we know of where one genetic change can cause the cancer. That's not the case with breast cancer. However, people who are born into families where there's a high frequency of breast cancers, there commonly are certain mutations that are present, and they're passed from one individual to another, from mother to daughter, father to son, and they're passed from generation to generation. And these mutations confer an increased risk for cancers to occur. So when we look at all of breast cancer, like Dr. Petersen mentioned before, and Dr. Bodiwali, about 1 in 8 women will develop breast cancer. And if we look at all these breast cancers, roughly 3/4 of them will not be associated with a genetic link at all. There won't be any increased frequency of breast cancer in these families. But in about close to 30% of families, there are actually, you will see increased incidence of breast cancer in those families. Now, most of these, some 20% of that 27%, these families will have mutations in genes that we don't really recognize as breast cancer syndromes. But in certain collections of, when certain collections of mutations are present, they can cause breast cancer. What I want to focus on is this group right here. And about 5 to 7% of all patients with breast cancer, they have a strong family history of breast cancer, as well as sometimes other cancers. One of the more common ones I'll talk about, commonly associated with breast cancer, is ovarian cancer. And these people here are said to belong to families that have breast cancer syndromes. And there are actually several of them, and only one of them, or 2 of them, that we commonly test for. So these families have a mutation in a single gene. And this gene, if it's being mutated, doesn't mean that every woman who inherits it will develop breast cancer. but there's a strong likelihood that she will. Much stronger than anybody in the average population without one of these mutations. So when we look at how these genes are passed from one generation to another, here's a father, and he's dressed in black because he's got the bad gene. So dad here has, if you look at the sperm, which these two shapes represent here, he has a big D, and he passes that big D. If he has 4 children, the chances are he's going to pass that particular sperm to 2 out of the 4 children, or 50% of his offspring will have the bad gene. Now, it doesn't matter. Maybe the mother could have had it. She would have had an equal chance of donating that bad gene to one of her offspring, whether it be boys or girls. It doesn't matter. So we call this kind of inheritance autosomal dominant. And all the breast cancer syndromes that we think of, they all transmit this bad gene in an autosomal dominant fashion. So that means that if the gene is present, if somebody is a carrier of the gene, a mother or a father, that 50% of their children will also end up being carriers and will be at high risk of developing cancer later on in their lives. This here is a list of the common breast cancer syndromes. And actually, of all these, I would focus on the first 2, because these are by far the most common. They're called the breast cancer and the breast and ovarian cancer syndromes. And they are caused by mutations in one of 2 genes, BRCA1 and BRCA2. And those acronym stands for breast cancer associated gene 1 and gene 2. Their mutations of these 2 genes are present in about 1 in 800 to 1 in 1,000 people throughout the population. However, they are associated with 5 to 7% of all breast cancers. And then, I mentioned, there are additional syndromes as well that are associated with other genes, but by far, these dominate the frequency at which we come across breast cancer syndromes in the population as a result of genetic predisposition. Now, like I mentioned, the human breast and ovarian cancer syndromes are associated with mutations of the BRCA1 or BRCA2 genes. And we actually find that there are roughly about 1,000 known mutations. It's not just that there's a same mutation that's found in every family. It's not the case. There's actually about 1,000 ones that have been reported. And when these mutations are present, the cancers that result, these cancers commonly tend to occur in younger women. The average age of diagnosis is 45 rather than in the mid to late 60s. These women have more aggressive disease, so their cancers divide more rapidly. They tend to oftentimes they are identified in between the annual mammogram visits. A woman might notice a lump in her breast all of a sudden, halfway through the year. This is how fast they can grow. Most other breast cancers that are not associated with family syndromes, they tend to grow a little bit slower. And the women with breast cancer due to one of the breast and ovarian cancer syndromes have worse prognosis. So these are the risks of developing different types of cancers in the presence of one of these 2 mutations. You can see in the general population for breast cancer, the risk is about 1 in 12.5, about 12.5%. But the presence of a mutation, if a woman is a carrier for breast cancer, her risk of a first breast cancer is 55 to 85, roughly 50 to 80% for each of these, for mutations of either of these 2 genes. And this is also striking. If a woman has 1 cancer, that's bad enough, right? But she's actually at very high risk of developing a second cancer. In the instance of BRCA1 mutation, 65% lifetime risk of developing a second breast cancer, 50% in the event of BRCA2 mutation. And that risk of a second cancer is much lower for the general population who have had a first cancer. Not only are women with these syndromes at risk for breast cancer, they're also at risk for ovarian cancer, thus part of the breast and ovarian cancer syndrome. The risk is higher for women with the BRCA1 mutation, 35 to 46%, and slightly less for but still significantly high for women with BRCA2 mutation, compared to the risk in the general population of only 1.5%. Also interestingly, males are not left out of the risk here. They're not left out of the picture. Men in the general public, we don't really think about men getting breast cancer, but just in the general population, we still see, about a 1 in 1,000 rate of male breast cancer. It's about 100 100-fold less likely to happen in a male, though. But in the presence of one of these two mutations, you can see that that risk goes up quite substantially for men. Prostate cancer also is on, men are at increased risk for prostate cancer, especially in the presence of a mutation for the BRCA2 gene. That risk goes up from general population risk of, actually I think that 15% is wrong, it's a little lower than that, but up to about 35 to 40% lifetime risk for BRCA2. And then also, interestingly, the risk of pancreatic cancer is also increased in these families relative to the general population. And so when we're assessing these families, we are looking for incidences of all these types of cancer to try and determine the risk that a family might have one of these syndromes. So when we identify women who are at risk, and I'll go over the criteria that we use in a moment, we look, when we order the test that we actually perform is a blood test. And generally, when we suspect an individual of having one of these syndromes, and it's not known to be present in that family, we actually have to sequence the whole gene, or send a blood specimen to have the BRCA1 and BRCA2 genes sequenced in their entirety. And because those genes are very big, we're talking, I think BRCA1 is something like 125,000 base pairs. They don't sequence the whole gene, but they sequence the parts that actually code for the protein. That sequencing of the whole gene to try and find a mutation anywhere along its length costs roughly $3,000. Now, if a family has a known mutation in one of these two genes, if we know ahead of time where to focus our attention to look for the mutation, the cost is limited because they can focus the sequencing directly over that area of the gene. So the cost is a lot less, oftentimes around $300, $350. What else I want to say here? Oh, and just, there are patients who are we are considering for testing. Ideally, we should refer them for genetic counseling. There's an important role for counseling. We have a social worker in our clinic who does provide quite a bit of pre and post-testing counseling. There are certified genetic counselors around the country that perform this role too. The role of genetics counseling basically is to take a full family history, to look for families that have appropriate risk that really should be tested, to discuss the risks, benefits, and limitations of cancer testing, to counsel all the family members who might be affected, and especially after the first member is identified, to bring in other family members who might be, for whom there might be an interest in having testing done. Also, these genetic counselors work with insurance companies to help them obtain coverage for testing, which is very expensive, like I described. And then, importantly, these counselors assure that confidentiality is maintained when they're working with these families. Now, who should be tested? Now, these are most of the guidelines. I didn't have room for all of them, but these are the most important ones that we use actually in our day-to-day assessment of patients with breast cancer. And these, importantly, these are derived from guidelines that are put together by a group that we call the National Comprehensive Cancer Network. And this is a network of experts around the country. They collect experts from all different cancers, and they contribute guidelines that tell us as practitioners of medical and surgical oncology how to best practice our oncology care. And so these guidelines, importantly, obviously, if there's an individual in a family with a known BRCA1 or BRCA2 mutation, they should be tested. For women, if there's a woman who is 45 or younger with breast cancer, she doesn't need any other criteria. She fits criteria for testing right there. By virtue of her age. If for a woman who's 50 or younger and who has more than one relative, especially with breast cancer that occurred in that relative, one of those relatives at an age younger than 50, or if she's less than 50 and she has a relative with ovarian cancer, she fits criteria for testing. Now, in a woman who has had her own personal history of 2 breast cancers, and the first one occurred before she turned 50, she is a candidate for genetic testing. Any woman who's diagnosed at an age under 60, who has a certain type of very aggressive breast cancer that we call triple negative because of some of the features of the cancer. That means that they don't express the estrogen receptor that we and some 2 other important proteins that we look at. These women should be tested. Women who are younger than the age of 50 and we don't know the family history, so we can't determine whether or not they might actually be at risk, we should go ahead and proceed with testing, or at least recommend testing to those individuals as well. Males, if there's a woman that comes to clinic and she has a male in her family with breast cancer, that automatically we should recommend testing to her as well. And then something I didn't really mention, but there's a strong link of mutations in BRCA1 and BRCA2 in family members of Ashkenazi Jewish heritage. And these are typically, these families tend to come from Central Europe. There are 3 common mutations that are present in these families. These families of Ashkenazi Jewish heritage have a much higher incidence of mutations in BRCA1 and BRCA2. Any woman of Ashkenazi Jewish heritage fits criteria automatically to be tested. Any woman with a history of ovarian cancer fits criteria. Except men with breast cancer. A woman with breast cancer who has 2 or more relatives with pancreatic cancer also fits criteria. And finally, any woman with a history of pancreatic cancer and who has 2 or more relatives with breast, ovarian, or pancreatic cancer at any age should be tested. So those are all complex, but these are the criteria that we search through as we're trying to figure out, if a patient who comes to see us, if it's right to recommend testing for her. So what are the benefits of genetic testing? Well, provide reassurance, reduce uncertainty with regards to one's risk. It helps by finding out if somebody is positive for one of these mutations. It helps in the decision making about how to best help that person or that woman prevent breast cancer. There are options that we can offer to women who test positive, which I'll briefly go over, including risk-reducing surgery and anti-hormonal medication therapy. How we can help assess risk of family members, and these test results can actually have an important impact on helping women to make decisions about how to plan having children in the future. Risks of genetic testing. A positive test result does not mean that a woman will actually develop breast cancer, but it does, as I've shown, substantially increase the risk. Risk of genetic testing, many people are concerned about the risk that a positive genetic testing result will have on their future employment, prospects of future employment or future insurance. Well, as many of you know, in 2008, there was a federal law passed called the Genetic Information Non-Discrimination Act. This law forbids companies, insurance companies, and prospective employers from discriminating against people who test positive for one of these for one of these genetic mutations, as well as for any other type of genetic disorder, from being discriminated on in terms of future employment or insurance, health insurance coverage, but does not protect a person from, it does not prevent companies that sell life insurance companies from preventing offering life insurance or long-term disability to people who test positive, only health insurance. So also, one of the significant risks here is that obtainment of, so sometimes a family looks like they have a strong family history, a very strongly suspect history of a breast cancer syndrome, and they end up getting a negative result. How to interpret the negative result is very challenging. There are other genes that are associated with BRCA1 and BRCA2. Mutations can occur in these genes and cause the same type of picture. These tests don't pick up on those mutations in those genes. Also, there can be loss of a very large segment of either the BRCA1 or BRCA2 gene, and actually what we call a rearrangement. That means a piece of the gene is transposed to somewhere else in the genome. The sequence is still normal, but the gene doesn't function anymore. When we when we test a patient, we come back with a normal sequencing result because the sequence is all intact. It's just the gene now doesn't work. So how to counsel, it becomes a challenge then to help patients understand what their risk is and what a negative result means. Also, some women end up with a result that is described as a variance of uncertain significance. That means that we find mutations that we really don't know what the role is in causing breast cancer. Because those mutations are not associated with the breast cancer syndrome as far as we're aware in other families. So once we've identified positive families or patients who test positive for mutations, How do we proceed from there? How can we help them reduce the risk of cancer? Well, one thing is through surveillance. And for women, if a young woman is identified as having one of these mutations, she should first of all begin self-breast exams beginning at age 18. As Dr. Bodiwali explained, by the age of, starting at around age 25, it's recommended that women who test positive undergo breast exams 2 to 4 times annually, and also begin annual mammography and breast MRI surveillance. Both of these studies annually, alternating them about every 6 months apart, is ideal. Like I mentioned, these cancers oftentimes tend to come on and be found during the year interval in between mammograms, so it's nice to be able to alter an MRI with a mammogram to try and detect these before they spread too far. Also, because of the risk of ovarian cancer, women over the age of 35 should be screened for ovarian cancer with a transvaginal ultrasound, and also with the use of a blood test looking for an ovarian cancer marker called CA-125. Either over the age of 35 or 5 to 10 years younger than the earliest age of onset of ovarian cancer in the family. For men, again, some of these same criteria, or some of these same indications for surveillance, or recommendations, excuse me, for surveillance. Men should begin breast exams actually early as well, age 18. Breast exams should be done twice yearly by a physician, starting around the age of 25. And consideration should be given to a baseline mammogram, especially for men who have larger breasts and, or dense breasts. There are surgical options to help that we can offer to women to help reduce the risk of having cancer. And these are some of the most important options that we have available to really decrease a woman's chance of getting one of these cancers. Prophylactic bilateral total mastectomy, that means removal of both breasts. This can be discussed, these options are discussed with a patient when they come to us, regardless if they have a personal history of breast cancer or not. So even a woman with no history of breast cancer, these are still options we would discuss with them. And they can have a significant impact on reducing the threat of one of these very deadly diseases throughout the rest of their lifetime. So removal of both breasts reduces the lifetime risk of breast cancer. I said by up to 90%, but actually it's unknown, might be actually closer to 100%. So suffice it to say, it's a dramatic reduction in the risk of breast cancer. It also reduces the risk of a second cancer in the contralateral breast and improves overall survival in women with breast cancer. Like I mentioned, the risk of a second breast cancer is very high in women with one of these mutations. And by doing a double mastectomy, we are able to reduce that risk almost completely. Also, we should have a discussion with our patients about the option of removing both ovaries and fallopian tubes. And this is called the bilateral salpingo-oophorectomy. Big long name. Basically means removing both ovaries. And this is recommended after a woman turns 35 to decrease the risk of both. We know studies have shown that by removing the ovaries, this reduces the risk of breast cancer in premenopausal women and reduces the risk of ovarian cancer in all women. So it's a very important option for women, and we generally offer to get age 35 and over. It's recommended for women with the presence of either one of these two mutations, either after the age of 35 or once childbearing is completed and a woman desires to no longer have children. Finally, there's the option of chemoprevention. Now, this is a very confusing, it's a misleading word because we don't actually offer chemotherapy. Instead, what we offer is anti-hormonal therapy. And that's because many breast cancers are actually driven by estrogen. And if we can suppress or remove the stimulus of estrogen from a woman's body, we can prevent a lot of these cancers from happening. So tamoxifen is an anti-estrogen drug. It blocks the cell's ability to respond to estrogen. Tamoxifen decreases breast cancer risk in carriers with in women who have one of these mutations with a history of ER-positive breast cancer. So in women who have a history of estrogen-sensitive breast cancer, we know that tamoxifen reduces the risk of developing recurrent disease. Tamoxifen plus surveillance using mammography and MRI annually, like I said, is an option for women who do not want to undergo bilateral mastectomies. And finally, there's another class of drugs that we call aromatase inhibitors. Many of you may have heard of a drug called Arimidex or a drug called Femara. Right now, as of 2012, we don't have information about this class of drugs and their ability to prevent future breast cancer. Finally, but it is known that, so basically out of all the medicines that we have, tamoxifen is the one that we know of best. And it's been shown to reduce the risk of breast cancer by about 50% in women who take tamoxifen. And for right now, the data suggests that we should use it only for 5 years and not longer than 5 years. Finally, birth control pills are another option. You don't see it discussed very much, but modern birth control pills do decrease the risk of ovarian cancer. But the question is, what is the risk of causing breast cancer? For women who have breast cancer diagnosed 10 years further out than when they actually started birth control pills, their risk of future breast cancer is increased. In other words, if a woman takes birth control pills for 10 years, she's actually at an increased risk of developing breast cancer as opposed to somebody who takes it for less than 10 years. So for that reason, we don't really offer birth control pills as a significant option for reducing risk in women with BRCA1, BRCA2 mutations. Well, this concludes my talk, and thank you very much.
I'm going to be talking about surgery and radiation. And surgery and radiation only really affect the breast and the area where we're working with the cancer itself. And so it's when we talk amongst physicians, we call it local and regional treatment. And you all got this flyer. Did you notice the picture of all these young doctors? And this is when I came to town. They took this picture, and we've had the same picture pretty much ever since. But it got me thinking, because when I came to town in 1994, fortunately I joined a very progressive practice. I joined Dr. Craighead, who's here tonight. And in 1994, every general surgeon considered themselves a breast cancer surgeon. Multidisciplinary care was kind of spotty, hit or miss. Not everybody got it. There was a lot of new things happening with breast surgery, breast conservation, and so forth, but not every woman was offered that. And if people had a mastectomy, they frequently were not offered reconstruction. And 1994 is also the same year that the American Society of Breast Surgeons was formed. And it was formed to promote high-quality breast surgery, to make sure that the advances in breast surgery that had been developed with research was adopted and offered to all patients, breast cancer patients. And it was, the society was developed to promote breast cancer surgery as a specialty. And I have to say I'm kind of proud to have been a member of this organization since 1997 and to have brought a lot of advances to this town. My partner, Dr. Petersen, is also a member of this organization, and it has really improved things in this country. Now, surgeons are responsible for a lot of the fear that women have of breast cancer. The operations that we used to do were horrific. I just saw a woman lately. I brought her in because her daughter had breast cancer, and she'd had 2 breast cancers, and she'd been treated in the 1950s, and the scar was amazing. Her heart was basically just underneath the skin. We don't do those anymore. But surgery was the first real treatment for breast cancer. And the current operations that we do are much more limited and much more precise. And still, surgery is the main treatment for breast cancer. Breast cancer cannot be cured without surgery, and many women are cured with surgery alone. Now, when someone comes to see us, we don't always know what's going on. So to get a diagnosis, we have to get a biopsy. And back in 1994, when I first started, really the only way to get a biopsy, to get a piece of the tissue, to look at it under the microscope, is we had to do an operation to take a piece out And we do that much less now. We now do minimally invasive biopsies. We often do it, the surgeons, with ultrasound. The radiologists often do it with ultrasound or with mammogram. And this is one of the things that the American Society of Breast Surgeons pushed, because many women were not offered minimally invasive biopsies when, in fact, that was the best thing for them. And now it's rare that we need to do a surgical biopsy. Sometimes we have to do it. Sometimes it just makes sense. There's a few situations where it makes sense to be the right thing to do. When someone is diagnosed with breast cancer, it is a scary, scary thing. And you don't know the whole answer yet. You don't know where you're at. There are lots of tests. People have lots of questions. You're waiting. And you're always imagining the worst case scenario. And during this time, there's going to be actually a couple of conversations with your surgeon, because we tailor the treatment to the patient and to their cancer. And no two situations are really the same, and patients have lots of options. Sometimes they have fewer, some have more than others. But it takes some time for patients to figure out what they want. And which options they want to choose, and we give them that time, and they have that time. Now, in the past, you heard that there was a dictum, you always have to get a second opinion, and that's because in the past many women were candidates for breast conservation and it wasn't offered to them, or they're candidates for breast reconstruction and it wasn't offered to them. And so that's really where that dictum has come from. Most women, the vast majority of patients we see, have time to make a well thought out decision about what they're going to do about their breast cancer. You have time to get a second opinion if you want to get a second opinion, and it's not going to hurt our feelings if it does, and if it does, it doesn't matter because it's not about us, it's about you. But if someone decides to get a second opinion, I would strongly suggest that they see a surgeon who's a member of the American Society of Breast Surgeons. Now, when we treat a breast cancer, we have to treat 3 different levels. We have to treat the tumor in the breast. We have to treat the lymph nodes under the arm, which is the first place where breast cancer tends to spread. And we need to treat the whole body. And I'm going to talk about the first 2 levels because the medical oncologist, Dr. Breier, is going to talk about treatment of the whole body. And so when we treat the breast itself, you've got a tumor in the breast, and our goals for treatment are to get it out before it has a chance to spread, and to get it out so that it doesn't come back. And that's called recurrence if it comes back. Traditionally, what we used to do, and we still do, is a mastectomy. And a mastectomy works. It's a simple operation. I mean, these are not the horrific operations of the past that we were talking about. It is a simple operation. Sometimes it's necessary. Sometimes patients don't have an option for breast conservation. Patients usually recover from it pretty quickly. And some women prefer a mastectomy. They don't have to go through all the steps that it takes to do breast conservation. If we're going to try and do breast conservation, people need to remember that in the vast majority of cases, it does not reduce the chances of beating the cancer. But it does require additional steps, probably the most significant of which is to get radiation therapy. So if you're going to have a mastectomy without reconstruction, Dr. Marten will talk about breast reconstruction. But mastectomy without reconstruction, patients usually avoid radiation. There's some circumstances where they might need it, and we could talk about that, and we would probably have maybe a clue beforehand. It's a usually well-tolerated surgery. Patients usually want to go home the day after surgery. I've had some patients who want to go home the day of surgery, and they usually are surprised that they have little pain. The trouble with a mastectomy is this. To some women, they don't care. And to other women, this is a big deal. And this is where it boils down. It is the patient's choice. If patients want to take the extra steps to save their breast, then it makes sense to do that if they're a good candidate for breast conservation. But if they don't want to take the extra steps and they're happy with this, it doesn't make sense to be doing all that. Breast conservation. I'm a fan of breast conservation, and we do a lot to do breast conservation. The First, if we're going to attempt breast conservation, the patient has to be a candidate. If you have a really big tumor or lots of cancers in the breast, patient's not going to be a candidate. If we're going to save the breast, we have to do a few things. First, we have to get it all out and know that it's all out, and that sometimes takes more than one operation. The patient has to have radiation afterwards, and we have to follow them with mammogram afterwards. And this is the deal where I've had a few patients say, gosh, I wish I had a mastectomy, because you're never going to have a normal mammogram again. Your new mammograms, we're going to follow you, and you're going to be called back, and sometimes that has caused people to be a little bit scared. And I think if patients are warned that that's the case, and that's fine. If we do breast conservation, there's a small but real risk of the breast cancer coming back in the breast itself. It's not the same thing as spread over the whole body, but coming back in the breast itself. If the breast cancer were to come back in the breast itself, that means we have not been successful in saving the breast, and that means that you have to have a mastectomy at that time. And so that's why I pretty much always say attempt to save the breast. The vast majority of the times we're successful. And remember that in most cases, the decision to have breast conservation does not affect survival, and it doesn't get you out of chemotherapy. If someone needs chemotherapy, a mastectomy wouldn't get them out of it. If they don't need chemotherapy, not having a mastectomy won't make them need it. And this study has been done over and over and over again. You enroll thousands of women in a study. They have the same kind of cancer, the same age of patient, the same stage of cancer. Everything's the same, and you randomize them with a coin flip. We're going to do a mastectomy in you, or we're going to try and save the breast in you. And you follow them for 10, 20, 30, 40 years. Some of the women who have a lumpectomy and radiation, a few of them will have, about 15% will have breast cancer come back in the breast, and they'll have to have a mastectomy at that time. But the same number of women are going to beat the cancer. So if someone's a candidate for breast cancer, you don't need to be afraid that it's vanity. If you're a candidate for breast conservation, you don't need to be afraid that it's vanity. It's not vanity. You're not risking your life to save your breast. I like to get a preoperative MRI before we operate, because every so often we find something. Here's the cancer, got a couple of points in here where we did a biopsy, and then this didn't show up on mammogram, but there it is. Now that we know it's there, well, what are we going to do? This patient elected to have a mastectomy. I suppose that's a satellite lesion. You might try and get that out with the same operation. But the preoperative MRI I've found to be helpful. If we do breast conserving surgery, patients are, again, they're usually surprised at how little pain they have. Patients usually are able to go home the day of surgery, and we try to hide the scar. In this case, we tried to hide the scar along the areola, the edge of the areola. And there may be a dressing changes that they need to do around a radiation balloon, and we'll talk about that. If we're going to save the breast, patients need radiation. And there are very few, kind of very, very limited cases, very elderly patients with low-grade non-invasive disease. Breast radiation has some side effects. All of those side effects are local. It doesn't make your hair fall out, doesn't make you lose weight. You know, they're all local. And they're usually some redness and peeling of the skin when you're getting the immediate effects, and there can be some long-term changes of the breast. Traditional radiation therapy, we treat the whole breast 5 days a week for 6 weeks. They sit you down in front of the machine, they turn it on for a few seconds, they turn it off for a few seconds, and the radiation has to go through the skin to get into the breast where it works. And because the radiation beam passes through the skin, we get a lot of changes and side effects to the skin. And so they have to give a lot of little tiny doses to try and reduce the side effects to the skin. And that causes some blistering. And so we now have a newer way of giving radiation, which is called accelerated partial breast irradiation. In this case, we give the radiation from the inside out. The skin's not so much of an issue. And the way we do this is we put a balloon inside the cavity when we do our lumpectomy, and the radiation doctors park a seed in the middle of that cavity twice a day for 5 days. I'm going to kind of blow through this fairly quickly to kind of keep the talk short. Not everybody is a candidate for the 5-day radiation. There are some criteria, and in this patient, I think, feel like she had her hands up 5 days. You know, look at the first criteria. I think her picture was taken in 1994 too. So it would be more likely if we had an older patient there, because the younger patients typically aren't good candidates for this. But basically, we place a space-holding balloon at the time of surgery until we have the final pathology report. When we get the final pathology report, we deflate that balloon and slip in a new balloon that is the actual treatment balloon. And there are certain criteria that it has to meet. I'm not going to go through every one of those. And the final criteria is if they can use the balloon radiation, is they're going to get a CT scan in the radiation center. If that's all favorable, then they get the 5 days of radiation twice a day for 5 days. And when they're done with the treatment, we deflate the balloon, and it slides out easily and heals up. So that's the breast itself. The next level is the lymph nodes under the arm, and that's the first place where breast cancer tends to spread. If there's cancer there, we need to know it because it changes everything. And if there's breast cancer in the lymph nodes under the arm, we'd like to get it out of there so it doesn't spread from under the arm. Now, traditionally, we used to do what's called an axillary dissection, and we just took out all of the nodes from underneath the arm in any patient that had breast cancer whenever we did their breast cancer surgery. And the trouble with that approach is that some women will have a swollen arm permanently, and some of those women that had the swollen arm didn't have any cancer in those lymph nodes. So it's kind of a complication of the operation they didn't need. We now do what's called a sentinel lymph node biopsy, and the way this works is we sample the first lymph node in line. We take that one out. Sometimes there's 2 or 3. And if there's no cancer in the first lymph node in line, we can be pretty dang sure that there's no cancer in the rest of the lymph nodes, and we can leave them alone. If there is cancer in those lymph nodes, well, you need to have the axillary dissection. You may have a swollen arm, but at least you know you need the operation. So this is a picture. We find the first lymph node in line by injecting a tracer into the breast. It goes to the first lymph node, and then we check out that first lymph node. It comes out at the time of surgery. And here is a picture of it. It's got the blue in it, and we can see our pathologist looking at it under the microscope to see whether there's cancer in there. So in summary, if we're going to treat the breast itself, we can have a mastectomy with or without reconstruction. If you're going to have breast conservation, there are extra steps we have to do. You have to get it all out. Might require more than one operation. We have to have radiation therapy. We have to have follow-up mammograms. We have to accept a small but real risk of the breast cancer coming back. But it does not affect survival and does not affect people's risk of beating the cancer. For the armpit, for the axilla, the lymph nodes under the arm, we do a sentinel lymph node. We only really do the axillary dissection in patients that need it. And in summary is that our treatment is tailored to the patient. There's not one size fits all. And I give one more plug for this organization that Anne and I both belong to. Thank you.
Thank you, Janet. I think I can keep this under 8 minutes. I just saw my son back there, so no one's allowed to leave. If he can make it this late, everybody's going to have to stay. I am glad to be able to contribute to the treatment of women with breast cancer. Even though I'm not curing their cancer, I'm trying to make them feel whole again, and this can be very meaningful as well. After all, this is not just cosmetic, but we are losing a normal body part, and we are trying to reconstruct that to feel normal again. I'm also a fan of breast conservation, as Dr. Roberts said. However, he also mentioned it's a very individualized thing, and I completely agree. Taking a large lump of tissue out of a small breast and then having radiation can sometimes result in a very disfigured appearance, which would be kind of hard to call conservation. On the other hand, reconstruction is definitely more surgery, a mastectomy, and the sensation is never the same. My goal, and I participate with general surgery and breast surgery in both conservation and reconstruction, is to give women the best appearance and symmetry that I can. I'll go through a couple of the latest advances in breast conservation. One is called oncoplasty, which involves using a plastic surgery technique that can be used in women with large breasts, which is basically a breast reduction. And if the breast cancer happens to be in the excess tissue that you would normally discard, then you can reduce the breast with a nice shape and size and then have radiation rather than having kind of a chunk of the breast missing, if you can imagine that. In those situations, another technique is partial breast reconstruction, where we can try to reconstruct the part of the breast that has been removed. The rest of my talk will focus, however, on breast reconstruction.
Breast reconstruction is a physically and emotionally rewarding procedure for a woman who has lost a breast due to cancer or other conditions. The results of breast reconstruction can approximate a natural appearance and feel, and can greatly improve a woman's self-image, self-confidence, and quality of life.
So, reconstruction can be done in two main ways. One is the use of silicone implants, and the other is the use of a woman's own tissue, sometimes taken from the abdomen, the back, or other places. Each way is perfectly acceptable and has its pros and cons. Flap surgery is the rearrangement of your own tissue. That tends to be a longer recovery that could involve anywhere from 3 to 7 days in the hospital. But long term, the breast tends to remain natural, with a natural appearance and natural feel for the rest of your life. The silicone gel implant is a smaller operation up front, but sometimes your body can form a capsule around it. That capsule can get hard and sometimes may need to be removed. The silicone implant is not a lifetime device, just like a heart valve or a knee replacement. 20 years later, you may need to have this replaced. If you do go the route of silicone gel implant, it's generally very hard to do the whole reconstruction at the time of mastectomy in one surgery. Without taking tissue from some other part of your body, what we do is expand the tissue that remains after mastectomy, which includes the skin and muscle, and we do that slowly by inflating it with saline, which is the same thing you would get in an IV. Once that reaches the size that you're happy with, we exchange that for a permanent implant. Tissue flaps, like I said, can come from your abdomen or your back. Sometimes the ones that come from your back need an implant to give the sufficient size to make a breast, and that's a combination of both techniques. If it comes from your abdomen, some women have enough tissue there to reconstruct either one or both breasts. The trade-off generally is that it can involve taking a muscle from your abdomen, what people know as the six-pack. You know, sometimes those muscles need to be used to allow the skin and soft tissue to survive. These can obviously leave scars at different places in your body, and even though women are losing a muscle from that area of their body, most, unless they're extreme athletes, function fairly well and don't notice much of a difference. Now, there are some newer techniques called free flaps, and these involve microsurgery. In the example of the abdomen, it involves sparing the muscle and completely removing that skin and soft tissue, and then sewing it up to your chest wall using a microscope and a tiny little sutures in the blood vessels. Anywhere you have excess tissue, this can sometimes be done. The buttocks, even the inner thighs. Now, while this seems very appealing and certainly is a great technological advance, the surgery can take all day and is very tedious, and if that little blood vessel fails, the whole flap can die, and then you would have to start with another plan. So I think that it's a great option to know about, but if women want this done, I recommend they go to a center where it's done every day, because it's very, very specialized surgery, and usually it's done by a team of multiple surgeons at once.
Flap techniques may result in a more natural feeling breast. and are performed when little tissue or muscle remains following mastectomy and will result in scars at both the breast and donor site and require a lengthy recovery. A tram flap uses donor fat, muscle, and skin from a woman's abdomen to reconstruct the breast. The flap may remain tethered to the original blood supply and is tunneled up through the chest wall, or the flap may be completely detached and formed into a breast mound using microsurgical techniques. In some cases, where a tram flap is not recommended, a free flap using fat, muscle, and skin from the buttocks, abdomen, or thigh may be used to reconstruct the breast. This requires full detachment from the donor site and blood supply and special microsurgical techniques. A latissimus dorsi flap tunnels muscle, fat, and skin attached to its original blood supply under the tissue of a woman's back to the chest wall. Occasionally, the flap can reconstruct a complete breast mound, but more commonly provides the muscle and tissue necessary to cover and support a breast implant. While a few cases of mastectomy leave sufficient tissue on the chest wall to cover and support a breast implant, most do not. The alternative to a flap and breast implant combination is the use of tissue expansion. This requires an expander to be placed underneath the chest wall skin and muscle that is periodically filled with sterile saline solution over many weeks until an appropriate sized breast mound is obtained. Once filled, the expander is sealed and serves as the breast implant, or it may be replaced by a permanent breast implant in a second surgical procedure.
No matter what type of reconstruction you choose, it usually involves more than one surgery. An excellent result can be obtained with any of these types of reconstruction, but results can vary. The final process usually involves doing something to the other breast if needed to create symmetry and make them look even. That can involve a lift, a reduction, or even an augmentation. The final step involves the creation of the nipple areolar complex, and this is usually done a few months later.
As swelling resolves and breast shape and position settle. Secondary procedures will reconstruct your nipple and areola.
Breast reconstruction is not for everyone. If you have severe medical problems, you might not be a candidate. And certainly, I don't push it. I'm a doctor first, I'm a plastic surgeon second. But most women with appropriate medical clearance and care can have breast reconstruction safely. I wouldn't be doing it if I didn't think it was safe. However, women need to know that this is a process that can take months, sometimes over a year, before the final result is obtained. And many women simply don't want to go through more surgery. That's a very personal choice, and I respect that. My job is to try to find the best thing that's right for them. Overall, women who do undergo breast reconstruction are quite satisfied with the results. No matter what I've said, I think the most important thing for you to remember is early detection or prevention can really maximize your options for both treating a cancer and having the best outcome in reconstruction possible. I'm going to leave you with a quote from Dr. Tagliacozzi, who was an Italian plastic surgeon. We restore, repair, and make whole those parts that nature has given, but fortune has taken away. Not so much that it may delight the eye, but that it may buoy up the spirit and help the mind of the afflicted. Thank you for coming tonight.
Well, hello. Thank you all for coming. I see a lot of faces I recognize in the crowd and some people I've never met before, so I'm glad everyone could make it tonight. I have sort of our introduction topic where we really talk about breast cancer in general and a question about some myths and some realities of what are breast cancer risk factors. What can you do to sort of support your health and perhaps avoid breast cancer? And what can you do to keep things as smoothly as possible? So I'm going to start with just some of the basic facts about breast cancer. As you can see on the slides, breast cancer is the most common cancer in American women after skin cancers. It's also the second leading cause of death in women from cancer. Lung cancer is the first cancer death in women. And for women, for those of us in the crowd, out of every 8 people, 1 person is likely to have breast cancer. So an individual woman's risk is about 12% for all comers. The National Cancer Institutes in America have predicted the numbers for 2012, and the predicted numbers for America in 2012 is that there will be 226,870 new cases of invasive breast cancer. There will also be 63,300 new cases of non-invasive breast cancer, and you may have heard of these. These are things like DCIS or LCIS. And there will be 39,510 deaths from breast cancer. The good news, because that's kind of a terrifying slide, is that the death rate from breast cancer has been declining since about the 90s. We think that that's mostly because of increased awareness, better screening techniques, more people getting their mammograms and keeping those appointments, and earlier detection and improved treatments. So let's talk about risk factors. That's really what this talk is about. And so the question is, what is a risk factor? So anything that increases your chance of having a disease is a risk factor. So we all know smoking is a risk factor for lung cancer. Just because you have a risk factor, or more than one risk factor, doesn't mean that as a result you're going to get the disease. So we've all known people who've smoked their entire life long, multiple packs, never once had lung cancer. And then we know these unfortunate people who've never once had a cigarette, weren't really even around secondhand smoke, but they've been diagnosed with lung cancer. So while risk factors influence the chances of getting a disease, they are not the be-all, end-all. Having one doesn't necessarily mean you get the other, and not having it at all doesn't necessarily mean you're saved from getting the disease. Most women who have multiple risk factors, 1 or more, of breast cancer will actually never develop breast cancers. Okay, so I just want to stress that a risk factor isn't the sort of doom that it needs to be. And many women who have breast cancer, again, have no risk factors. So when we look at risk factors, there's really 2 kinds. There's risk factors you just have in you and you can't do anything about them. They are, you're aware of them. And then there's risk factors that you can change and influence. So those are the ones that we as individuals can take some ownership of and do something about. So let's talk about the ones you can't do anything about. Most of you in the audience are women. That alone gives us a risk factor for breast cancer. Men can develop breast cancer, but women have 100 times greater risk of breast cancer than men do. Our age increases our risk of breast cancer. The older we get, the more likely we are to develop breast cancer. If you're younger than 45, the risk of breast cancers found in women, the women under 45, there's only 1 in 8 women who develop breast cancer. As we get over the age of 65, 2 out of every 3 breast cancers are found in women over the age of 65. So the natural process of aging makes breast cancer more likely. Genetics play a role in breast cancer, and we're going to have another talk with Dr. Laux about that here in a little bit, so I'll let him delve into the details of genetics. Family history plays a role, but the thing to remember is that the majority of women in America who've been diagnosed with breast cancer have no family history of breast cancer. So once again, having a family history increases your risk, but most women do not have a family history. And your personal history of breast cancer also plays a role. If you've been diagnosed with breast cancer before, the chance of having another breast cancer in your lifetime increases by 3 to 4-fold. And that's not a recurrence sort of with this one breast cancer never quite got taken care of. That's of a new breast cancer forming. So personal history can be a risk as well. There's some more risk factors. Our race, white women, Caucasian women, trying to be politically correct, those who look like me, your risk factor is higher than those who are African American, Asian, Hispanic, Native American, Caucasian women have a slightly higher risk of breast cancer compared to others. Women who have dense breast tissue. You can't do anything about having dense breast tissue, but if you've had a mammogram that has told you that you have dense breast tissue, that's not diagnosed by physical exam or by somebody once said something. If a mammogram said you had dense breast tissue, you have a slightly higher risk of breast cancer. There's also certain benign conditions that when biopsied give you a slightly higher risk of breast cancer compared to others. Menstrual periods do carry a risk. The more you've had, the slightly higher your risk of breast cancer. Again, you can't change this. So if you started your period at a very young age, or you started menopause at a very late age, that predisposes towards breast cancer slightly. It's a slight increase in risk. Chest radiation under the age of 40 is also a risk factor. There are some children who get cancers who get radiation to treat those cancers at a young age. They are at increased risk of breast cancer as well. And then DES exposure is also a risk. So what are some things that are what we call lifestyle risk factors? These are the risk factors we sort of have some influence of, although you may look at it and think we don't have quite as much influence over it as you think. Having children. Women who have children before the age of 30 have a slightly protective predisposition to avoid breast cancer. If you wait till after the age of 30 or you've never had a child, you have a slight increase in risk of breast cancer. Oral contraceptives have been shown in a few studies to show an increased risk in breast cancer. Once you've been off of birth control pills for about 10 years, your risk falls back to the same as any other woman of the same age. But for younger women who develop breast cancer, it has been shown that birth control pills can have some influence. Hormone therapy after menopause we know has been related to breast cancer risk. There are times when it's given for different things and in the past was used a little bit more frequently. It's something we're really trying to slowly get away from now because it has definitely been shown to have an increased risk of breast cancer. Breastfeeding is kind of a question. There have been several studies that have shown if you breastfeed, you have a decreased risk of breast cancer. But those are only in women who breastfeed for at least 2 years continuously. That doesn't happen so often. So that's in other countries more than it is in ours, although if you're one of those who does breastfeed for a full 2-year period, then you would have a slightly decreased risk of breast cancer. Alcoholic beverages. We know that women who drink 1 alcoholic beverage a day, no increased risk of breast cancer. So you're all good. If you drink 2 to 5 alcoholic beverages per day, there is an increased risk in breast cancer. It goes up about 10 to 12%. And then my favorites, diet and exercise. Why is it that every possible disease that we find, somebody tells us we need to lose weight and exercise more? But that's true about breast cancer too. So we know that being overweight does increase your risk of breast cancer. It has to do with the fat in our body have a higher circulation of estrogen. But the good news for a few of us in the room is that that only counts after 40. So you have until 40 to lose your weight. And then you have to be normal weight for the rest of your life and exercise. And it's a big task. Physical activity, they have found literally as little as 1.5 hours per week. 30 minutes of brisk walking 3 times a week decreases your risk of breast cancer by 18%. So once again, diet and exercise. I get tired of hearing about diet and exercise, but I do it. Not perfectly, but I do it. So what aren't risk factors? So you go on the internet and there's all kinds of really interesting things that they say cause breast cancer. Deodorant does not cause breast cancer. Wearing a bra does not cause breast cancer. Having an abortion is in no way relinked to breast cancer. Breast implants do not cause breast cancer. There's some question about cigarette smoking. There's a new study out that says maybe there's an increased risk of breast cancer. But it's not proven, so it's still on my not risk factor slide. Chemicals, environmental chemicals. Never once been proven that a single environmental chemical, whether it's in our food, whether it's in our air, whether it's a place you work, none have been definitively linked to breast cancer. Working the night shift is also one that deserves a question mark. There's also a new study that says if you work nights instead of days, it changes your cycle a little bit, and you might be at a slightly increased risk of breast cancer. But the studies are not conclusive. More studies are needed. Nobody believes the results to be able to put it on the risk factor list. So that's breast cancer risk factors. And now it's time to learn more.
So we're going to talk about screening for breast cancer. So I'm sure a lot of women in the audience know what a mammogram is, but I just, for the sake of completeness, I wanted to include what a mammogram is. Basically, we are using x-rays to image each breast, taking pictures of each breast, so that the radiologist can look at the images and identify any problem areas that may indicate cancer. So this is the dreaded mammogram that everyone is scared to have every year. You know, someone squishing down on your breast is not a pleasant feeling. These are the the compression paddles that we used to obtain the mammograms. This is something I found. So as a guy, I can understand the the torture of going through and having a sensitive body part imaged every year. All right, so we basically obtain a couple projections of each breast. We call these the CC and MLO views of both breasts, and they kind of look like this. So as you can see, based on these images, the radiologist has to determine what part needs more attention or whether everything is normal, and then the patient would get a normal letter, or they would have to come back. So there's a lot of talk about radiation. We get exposed to radiation in all sorts of different places, but how much radiation do you actually get from a mammogram? It's about 0.1 to 0.2 rads of dose that you get per x-ray. And to put that in perspective, if you take a flight from New York to California, it's the same amount of radiation that you would get from having a mammogram done. Sort of the same risk if you were to smoke 8 cigarettes. There are all these different numbers that people come up with, but the point being that mammograms are not causing cancer by radiation. It's a very, very small amount of dose that you get when someone gets their mammogram. I just wanted to kind of throw in a few slides about what the radiologist is actually looking for on the mammograms. Basically, we are looking for 3 things. We are looking for masses, whether they are benign or malignant. We are looking at calcifications, again, same thing, benign or malignant. And we are looking for some sort of an architectural distortion in the breast parenchyma. Just wanted to throw out some examples, and I have included on the slides, which one of these are benign and which one is not. The image on my left is of what's called a fibroadenoma. It's a benign tumor of the breast that we see every day. And then the image on my right is one where is a spiculated mass in the breast that is malignant. A couple image of calcifications in the breast, and you can see these kind of calcifications are benign, whereas these ones, the ugly looking ones, are malignant. And we have to sit in a dark room. Everyone makes fun of the radiologist, but this is what we are looking at because we need a dark room to focus on these calcifications and masses and things like that. As you can see, things like this would be pretty subtle if the room is pretty bright. So we have to sit in a dark room and focus on things like this to pick them out on a mammogram. Okay, so why is screening important? Anne actually gave us a fabulous talk about risk factors, and I'm going to use a couple of the same numbers over here. 1 in 8 women diagnosed in their lifetime with breast cancer. Okay, mammography has reduced the breast cancer mortality by 1/3 since the 1990s. Mammograms can detect early cancer, and that's the goal of the radiologist, is to find something early so that it's more treatable in the early phase, so that a patient does not have to go through some of the disfiguring changes later on with more advanced kinds of cancer. And Anne already spoke about this, but 3 out of 4 women diagnosed with breast cancer have no family history of breast cancer and are not considered high risk. That is why we have to screen the whole population and not just people with breast cancer. All right, so I'm not sure how many in the audience are aware of the task force recommendations that came out in 2009. But the caption here says, we now recommend shifting mammogram recommendations to after age 50 unless we change our recommendations annually to new, more confusing recommendations to recommendly speaking. So the point is this, there is a lot of confusion out there about when to screen, what age to screen, do I need to screen with mammogram, do I need to do something else? So hopefully I'll try to sort some of these things out in the next few minutes that I have here. Okay, so first, we have to, I'll go over the task force recommendations that they gave. So basically they said that, we should start screening every 2 years beginning at age 50. And that, screening before age 50 should be an individual decision left to the patient, whether they would be more in favor of getting a false positive. I'm going to get into some of these things later, but anyway, let me just finish with the recommendations. They said that there was insufficient evidence for additional benefits and harms of screening in women ages 75 or older. The recommendation was against self-breast exam, and there was insufficient clinical evidence for clinical breast exam in women who are 40 years or older. And there was insufficient evidence of benefits and harms of using other modalities such as MRI for breast cancer. So now I'm going to talk about what are the problems with these recommendations. 1 in every 6 breast cancer occurs in someone who is age 40, between 40 and 49. So if we start screening someone at 50, we are going to miss 1 in every 6 breast cancer. Okay? For all the years of life saved by mammography, 40% are for women in their 40s. The 10-year risk of breast cancer in a 40-year-old woman is 1 in 69. And for women even 50 plus, if we were to only screen them every 2 years, then we would miss up to 30% of the cancers. So these are some of the drawbacks. There was a piece in the recommendation about the anxiety caused by screening and whether, so I just kind of wanted to put things in a little bit of a perspective. If we were to screen 1,000 women, we will probably call back 80 for more additional exams. 45 of those would get additional images of the breast and an ultrasound, which would turn out to be nothing. Out of that, 20 out of those 80 women, we would call them back in 6 months just to make sure that nothing changes. That means that the radiologist's view of anything bad going on is less than 2%. And in approximately 15 of these women, they will have a biopsy, and 5 of these will have cancer. So yes, there is some anxiety caused by, if the radiologist were to call you back in 6 months and get some additional images, or to call you back from screening to do some images. But we have to look at that in the perspective that if we don't do that, we may be missing 5 out of 5 cancers out of every 1,000 women we screen. So there is some anxiety involved, but I think it's not enough where we would not recommend getting a mammogram every year. So this is basically the recommendation of the American Cancer Society and Society of Breast Imaging, as well as the American College of Radiology, that women should begin annual mammograms starting at age 40, even if they have no symptoms or family history of breast cancer. So if you don't take away anything from this talk, this is the slide to focus on, beginning at age 40 and doing it every year. Okay, so Anne actually talked to you about some of these things, but I'm just going to hit them real quick. Who needs to get screening before age 40? If you have certain genetic mutations, which Dr. Laux is going to talk about, then you need to begin at age 30, but not before age 25. Women with mothers or sister, basically a first-degree relative who has premenopausal breast cancer, they need to begin at age 30 or 10 years earlier than the age of diagnosis of the relative with breast cancer. There are certain genetic tests available that can determine your lifetime risk of having breast cancer, and if your lifetime risk is 20% or more, then you can start screening at age 30. And like Anne talked about, if you have a history of prior radiation to the chest, usually for Hodgkin's disease, then you need to start earlier. And then there are certain benign conditions that you need to start screening whenever they are identified. Okay, when should screening stop? Everyone would like to have an endpoint, and this is basically the recommendation of the American College of Radiology. When the life expectancy is 5 to 7 years on the basis of age or other conditions, or if you have an abnormal result that would not change management, then that's when you stop. I've seen at least one patient since being here who has biopsy-proven cancer in her breast, and she doesn't want to do anything about it, but she still returns for her mammogram, which is kind of silly, but anyway. So what we've talked about mammograms. What are the limitations of mammography? We cannot find approximately up to 15% of the breast cancers are not detected on mammograms. And if someone has a palpable mass and we can't find anything wrong on the mammogram or on ultrasound, then it still needs to be worked up. Okay, so this is the bane of the radiologist's existence, a dense breast. It's hard for me to make out anything abnormal in these kind of breasts, and so we use sometimes other techniques to help us with these things, and I'll get into that a little later. So other than mammograms, we have ultrasound and MRI available for screening the breast. Ultrasound, it can be used as an adjunct to mammography in women who have dense breasts. And it has been shown that it can find up to approximately 3 to 5 more cancers in addition to mammography if you do an ultrasound of the whole breast. And they've done some studies in Europe where they have used ultrasound more so than in the United States. The problem with ultrasound is that it tends to be very user dependent. So it's technically a lot more challenging exam than just doing a mammogram. Plus, the calcifications that I talked about earlier would not be seen on an ultrasound. So it's still important to do mammography every year, even if we were screening with ultrasound. Okay. I just wanted to throw in some pictures because us radiologists, we love pictures. This woman had some large lymph nodes. We never could identify anything wrong with her breast. And anyway, this is an image of the lymph node on ultrasound. And we can use ultrasound to biopsy these lymph nodes too. So ultrasound has a role as far as biopsy is concerned. MRI, the recommendation is if you have a BRCA BRCA mutation, you can start annual screening by MRI at age 30. If you have untested first-degree relatives of people who already have that mutation, then you can start at age 30. I already talked about this. If you have a 20% or greater lifetime risk for breast cancer, then you can have an MRI yearly as well. I already talked about radiation to the chest, and those women can also get an MRI. Again, it's that same patient that I showed to you earlier. These are some large lymph nodes that we can see on MRI. MRI can also be used in women who have between 15 and 20% lifetime risk of breast cancer. This is a case where this woman, basically, she had a mammogram last year, she had a mammogram this year. If you compare these two, you can't really find anything wrong. But once she got an MRI, there was this mass that was not present or that was not detected on her mammograms that we can see on the MRI. So what are the limitations of MRI? It's expensive. Okay, the specificity is lower than mammography. Basically, we can find a lot of benign things that can look sometimes suspicious. So we need experienced radiologists to look at these images and then make the appropriate recommendations. So summary, mammography is not perfect, but it's the only screening test proven to significantly decrease breast cancer deaths. It will remain the primary screening test for breast cancer, and MRI and ultrasound may be useful in addition to mammography in certain populations. This is my daughter. Hopefully you got something out of this talk and you're not like her.